Deep Dive ECG Interpretation with Pekga, Practical EKG Academy. So today we're going to be taking a look at this 12-lead ECG. Now there's this exact same version of this ECG as a rapid ECG interpretation, so very brief with virtually very little or no explanation. This deep dive is exactly what it sounds like. We're going to be breaking down what we're doing, how we're doing, why we're doing this. So, and before I forget to mention, there will be a link in the description below for the rapid ECG interpretation version of this video. So you can check out the description below and click on that if you don't want to waste a whole lot of time going over what we're doing and how we're doing. So before we get into the actual ECG interpretation, I do want to show you the method that we're using. So a method is something that you will have to develop on your own. Well, you don't necessarily have to develop it, but it certainly helps quite a bit. And this is what we use at Pekga, something that we have kind of built up over the years, if you will. Our method consists of 3 steps. First step is the overview step. So really you're just looking at what stands out to you. So you take a look at the ECG and you're like, okay, what stands out to me here? The next step is the analysis step. And that's where you go into exact measurements. So literally we will go from left to right, starting with the P wave, PR interval, Q wave, QRS, so on and so forth, just right down the line. And we will also be taking a look at the QRS and R wave progression. So this is a step where the exact measurements yield a lot of information. So you'll get the most information out of step number 2 that will ultimately allow you to complete your ECG analysis. And finally, you cannot exclude the patient circumstance and situation. So if the patient was complaining of symptoms or what was the patient doing at the time, those are all questions you're going to be looking at or trying to answer if you can. And the whole point there is to corroborate what was going on with the patient, with what you're seeing on the ECG. And finally, if you have these 3 steps, the overview, the analysis, and you understand what was going on with the patient and the situation at the time, you should be able to do a full ECG analysis, which leads to a diagnosis. So ECG analysis is a part of a diagnosis. Going through the first 2 steps will not yield a diagnosis. Well, maybe you're that good, but typically it's not enough. Okay, so let's get into it. Again, we're building up to this 12-lead ECG, right? We're just going to break it down, and I'll show you here what happens, in a telemetry setting versus a clinical setting. So in a telemetry setting, typically you will be dealing with a single channel, maybe 3 channels. Depends on the devices that are being utilized and depends on the setup on the devices. The most common channel that's used in cardiac telemetry is channel lead 2. And the reason why it's used is, well, we'll come back to that right here. If you take a look at the hexaxial system, so once you're following depolarization that's going on in the heart, lead 2 right here, right? This is the tip of lead 2. This would be the apex of the heart. This would be your sinoatrial node, roughly speaking. So this is just orientation purposes. These are not exact locations. Exact locations of what's going on with the depolarization waves we cover in our lessons. And you can certainly check that out at pekga.com. Also, the graphics I will be using here today, with the exception of the ECG itself, you can log into our members area for free. There's no fees of any kind. You can just log in and download these ECG tools. They are high vector graphics, so if you scale them up, if you minimize them, expand them, they should remain in the quality degree of quality. They will not deteriorate in quality. Okay, so let's see here. Where was I? Oh yeah, lead 2. Okay, so going back to why we use lead 2. Lead 2 corresponds to major axis of depolarization in the heart. When I say major axis, I mean the signal, originates, or it's supposed to, in the sinoatrial node, and it travels down the heart, right, all the way down to the apex. Lead 2 mimics this path. That's why lead 2 is most commonly used. So going back to the lead itself, and I'm sorry, I'm just going to minimize my pen over here. Minimize. Okay. Yes. So somebody hands you this single channel. The only thing you can reliably pull off of any single channel lead is rate and rhythm. And I'm sorry, guys, this is just my setup today is a little bit off. Okay, so the only thing you can really reliably pull is rate and rhythm. And as far as the rate goes, that's pretty straightforward. Find a couple of your R waves, QRSs, and then just measure the distance between them. Now, what I like to do, if possible, I'll find a QRS that lands on this major line, or this thick line, and then I'll just use the 300 method. So 300, 150, 100, 75, 60, and this lies roughly 1/3 of the way between, so 1/3 of the way between 60 and 75, right? That's 15 beats of a difference. 1/3 of that will be 5, so I'm going to be just subtracting 5 from 75, and that should give us 70 beats per minute. Okay, so that's just a quick look at this, and where this is coming from is the 300 rule, right? So without going into a whole lot of detail where the 300 rule exactly comes from, we do cover that in our lessons, but you just take the number 300, you divide it by the number of big boxes. And going back to the, let me just find it right here. You can also download this at Pekga.com. It's a ruler. You can buy these rulers for, next to nothing all over the place, but you can download this for free, print it out, and do whatever you like with it, right? But over here you have the 300 rule in the top line. So, let's say your QRS was here, your next big box would tell you that the rate is at 300, 2 boxes down, 150, 175, 60. This is what I was doing a moment ago, right? The 1500 rule, which I'm going to cover next, is right down here. So this is your line for the 1500 rule. You can see if the difference between two QRSs was one small box, you would have a rate of 1,500 beats per minute, which is not really possible. Anyway, you can download this for free at Pekga.com. You do have to log into the members area. It is free. There's absolutely no fees tied to it, but that's what I was doing here a moment ago. So the 300 rule will give us 69.28 beats per minute. Nobody cares about 0.28. Nobody's going to care that there's a 1 beat difference here. Now, if the 300 rule gave you 59, and it turns out that I made a mistake here, 70, that is going to be significant. However, 1 beat difference, nobody cares. Now, the 1500 rule relies on the small boxes. So if you go in here, these small boxes, one of these big boxes, right, is made up of 5 smaller ones, 1, 2, 3, 4, 5. So then what you have here is you have 5, 10, 15, 20, 21, 22 small boxes. So the 1500 rule, you just take the number 1500 divided by the number of small boxes, and you get your beats per minute. Now here, there's a difference, right? Here we have 69, here we have 68, here we have 70. Anybody gonna care because of a 2 beat difference? Absolutely not. Absolutely not. So it is, the quick tip, or the quick estimate using the 300 rule works just fine. All right, so we have our rate. We're going to call it 70 beats per minute just for the sake of the argument here. for the ease of the argument, really. As far as the rhythm goes, now that's a little trickier. So here I'm looking at this, and P wave, P wave, P wave, P wave in front of every QRS, right? Looking at it, the P wave appears to be, and I'm sorry, my colors just keep on escaping today, but okay, so the P wave here is always present before a QRS. The PR segment and the PR interval seems to be consistent. So I would say that this P wave is married to the QRS, or this P wave gives rise to this QRS. Maybe, and I'll show you why on the, maybe not on the next slide, but the final 12-lead ECG. Okay, so one thing that kind of catches my attention here is this PR interval seems to be a bit longer. So I'm looking at this. This is 1 box, 2 boxes, 3 boxes, 4 boxes, roughly 4.5 small boxes. So this is, what is that, 180 milliseconds? 200 milliseconds is the cutoff for first-degree AV block. So this is kind of, almost borderline first-degree AV block. Now that in itself is not really significant. You do have to keep in mind how old your patient is. So if you don't know how old this patient is, do not ignore first-degree heart block. A lot of times it just gets kind of pushed aside. But if your patient is under the age of 50, first-degree heart block is significant. Okay, so moving on. What I have here is I have a P wave that appears to be married to this QRS. I'm not 100% sure, so the only thing I can definitively say here is that we have an atrial rhythm. So this is, I'm assuming it's coming from the atrium. The QRS itself is narrow. Just eyeballing it. My color, my goodness. Sorry, let me just switch colors here. So the QRS itself seems to be roughly 1.5 small boxes wide, which is 60 milliseconds. That's kind of quick. But it is good in the sense that the QRS is not wide. So I would say that we have an atrial rhythm. We have, or you could call it a supraventricular rhythm. The QRS is narrow. So there's a high chance that this is coming from above the ventricles, right? Now, I know that sounds confusing, and I know that might be a bit of a shock to some of you listening to this. What are you talking about? This is normal sinus rhythm, right, straight and forward at 70 beats per minute. You can make that assumption, but you would not be 100% accurate in making that assumption. All right, let's keep moving on. Okay, now we're looking at just the expanded version of that segment. So this is what we were looking at a moment ago. If we go back to it, this right here, this strip is exactly the same. It's identical to this one, right? Here we just have an addition of V1 and V5. V1 for the right side of the heart, V5 for the left side of the heart. Again, going back to the overview or the first step in the method, right? What stands out? Oops. And what stands out to me here is nothing. Nothing really stands out. A little bit of a Q wave down here, but this is non-pathological. It's not big enough. It's not wide enough. See that right here? So I would say that that's just septal involvement. So your QRS, right? That's related to the ventricular depolarization. A lot of times it kind of gets skipped or not really discussed, but where's my heart? Here it is. So as the signal moves from the AV node down into the ventricles via His bundle and bundle branches, the first thing that happens is the septum gets innervated from the left bundle, and then almost immediately it gets innervated from the right bundle as well. And this is where your Q wave comes on the QRS. That's where the Q wave comes from, right? Most of the time it's not visible. Most of the time it's just not visible. It gets kind of faded out or blocked out by other electrical activity, but this is where your Q wave comes from. Okay, and I think that's what we're seeing here is just a little bit of that septal depolarization. Nothing interesting. I am going to remember this though. Now, one thing that I do like to do here, and this is probably a great example of this, is the QRS. When it comes to the QRS, I like to find the widest beat possible, and I like to measure it out. I'll show you something interesting here. So here, I'm going to draw a line up here, and this is a good trick to use. Sorry, let me just make this line a little bit thicker. Okay, good. So here I'm measuring the QRS from the right, and where the R wave starts, where the depolarization starts going up, your first upstroke. When you compare that to what we were measuring earlier, look at this. So there's probably a little bit of a Q wave here that kind of I missed it, right? I did not realize that this is actually Q going down and then the R wave's going up. I just kind of went, whoops, sorry about that. I went straight over here, right? Mistake. But that's why you can correct this mistake by finding the widest QRS, right? See that? All of a sudden, we have a very different picture. So let me just copy this guy and look at this. Now, as far as finding where this QRS gets cut off, you need to understand how to measure how to find your J point. And when it comes to your QRS, right, your J point is kind of tricky. It's plainly explained as the point where your QRS comes back to the isoelectric baseline. And that's true. However, sometimes that's not easy to figure out. For example, on our little clip here, where exactly is your J point? You know, is that point right here? If that's the case, we have a wide QRS. Is that point right here? You know, is it somewhere in between? Well, let's take a look at this a little bit further. So first of all, you have to figure out where your baseline is. That's not always possible. The best way to do that under normal circumstances, I would say, is just find your PR segment and draw a line from that. So you'll find your PR segment and you kind of draw your line from that. That'll give you a pretty good estimate of where your baseline is supposed to be. Now, again, when you get into ventricular tachycardias and faster rhythms and things just don't look the way they should, this is incredibly difficult. This is incredibly difficult. So going back to the J point, right? So the J point is the point where your QRS comes back to the isoelectric baseline. The technical definition of that is it's the inflection point where your S wave, as it's coming back, here there's a very sudden cutoff, right? So this is a computer-generated image. It's a very sudden cutoff. On our ECG over here, you have a slope. I'll show you what to do. So this inflection point is the point where, if you were to draw a line of the slope at that line. Now this is tricky. If you were not good at your math, or your geometry class, so when it comes to a slope is rise over run. So rise over run. And if you were to draw a line from this point to this point, you will have a slope. Now, a sharp slope is a slope that has a far greater rise over run. So it moved up 2 and over 1. So this is a very sharp slope, right? So it's a sharp angle, right? If this was your baseline here, you have a very sharp angle. Here, the angle is not as sharp. This is roughly 45 degrees. This is maybe 60. Okay. If you have maybe not a great slope, you have a small rise over a longer run. Okay. So the angle here is even smaller. Okay, very aggressive, sharp slope, very dull slope. Oh, okay, so what happens is on this ECG here, well, let me go back to this one here, sorry, real quick. What you're looking for is the point where if you were to draw this line, and I'll show you what I mean by draw that line in just a moment, the angle after the, the angle, so let's say this is the midpoint, the angle after your J point or your inflection point and the angle before it of this line compared to your QRS or whatever EKG data that you're pulling off of it, they're equal. So this angle is equal to this angle over here. That's your inflection point and that's your J point. So going back to the ECG, I'm sorry, let me just tidy this up here. We might come back to it. I don't want to run into a mess. Okay. Oh, that's a lot of deleting. All right. Okay. So when it comes, when we come back to this right here, right, we're going to be drawing a line. Now this line here, and you can literally do this with a ruler. You just kind of move your ruler up and down a little bit, and you find a point where it appears that you're, now you will also have to move this ruler kind of up and down here and there in the beginning. So once you get good at this, you don't have to do this, right? But you're going to move your ruler around to kind of see where you get this point where the angle above and the angle below, they seem to be about the same. And then what you do is you take your line and you move it over here, and that's the end of your QRS. So that's your J point. And here, when we measure it out, when we measure it out, we have 1 box, 2 boxes, 2.5, roughly, boxes. So that's what, 80, 100. So this is 100 to 110 milliseconds. Versus on the first ECG we were looking at it, if you were to measure it out, this came out to be roughly 60. And look at the difference in the alignment. Look at that, right? So here it's 100 or 110 roughly, and here it's 60. Huge difference. So do not shy away from finding the widest QRS and trying to figure out, if your QRS is wide. Very, very important. Okay, now going back, right, overview analysis. Now, this is a deep dive, so I'm kind of going into the nitty gritty. A lot of you that are familiar with this stuff, feel free to kind of fast forward through it, right? Nothing else jumping out at me, so let's keep moving. And now we are getting to the 12 lead, right? Always, always, always go back to your method. Your method is going to save you when you're tired. Your method is going to save you when you are under stress, when you are forgetting things. So always go back to your method. First step is first, what stands out? And right here, really in your face, something is going on with AVL. This is low voltage. So there's something going on with this electrode where the voltage is severely reduced. First thing I would do is I would double check the electrode. Now, which electrode do you double check? For those of you who are, new to this ECG game, if you will, AVL corresponds to your left shoulder. Now, there is no electrode for AVR, AVL, or AVF. Those are augmented leads. They are calculated using the leads or Einthoven's triangle for leads 1, 2, and 3. So they are a mathematical derivation from whatever's going on with the overall signal that's coming from the heart. So there is no electrode. However, they do correspond to the electrodes that are placed on the left arm, or that is the electrode that's placed on the left arm. So the first one that I would check is whatever's going on over here. if that electrode is here, right? That electrode could be down here on the left arm as well, wherever you placed it. The Eindhoven's triangle, right? If we were to draw it on here, looks like that. And then there's, well, how can I explain this? That would make sense. Your axis related to lead 1 is composed of an electrode over here, an electrode over here, right? So there is an involvement on this side that could affect what's going on with AVL. So you have to double check this electrode as well. And again, it could have been placed down here on the right hand or arm versus the right shoulder. But first one I would start with is your left shoulder or left arm. Also, there is your lead 3, right? And this has one end up here and another end down here. So you could also double check this electrode, and this would be corresponding to your left foot, or left leg, whatever, left leg electrode. So there's 3 electrodes here that I would double check. Okay, I know that seems like a bit of an overkill, but that AVL, and sorry, let me just clean this up if we come back to it. So, okay, this is significant. And first you want to rule out any mechanical issues. So if you've ruled out your electrodes and they're working fine and it's still looking the same way, you got to double check your wires. If your wires are fine, it's still looking the same way, you got to check your machine. And let me go back to the electrodes, all of the electrodes, so not just the left arm, right? You want to check the right arm and the left leg as well. So double check everything. If all of that has been double checked, the machine is working fine, the wire is not kinked, you might have some inflammation or infusion happening around the heart or around the lungs. And what is going on there is, if you can see this here, imagine if you had some sort of a buildup around the heart or perhaps in the lungs. If you had unwanted fluid buildup, the signal coming from the heart would have a hard time reaching this electrode, and it might show up as low voltage. So do not ignore this. Do not, I repeat, do not ignore this. It could be mechanical, but I would not ignore this at all. Okay, let me just get rid of that and let's keep going. So that's my overview. That's what stands out, right? Now we're going to get into the nitty-gritty. So again, you take your PQRST complex and you just kind of go from left to right. However, when you're dealing with 12 leads, you can do this 12 different times if you really want to be thorough, right? I'm going to start on this side over here, and I'm just going to grab this QRS real quick. I like to do that. We use axis of deviation for a lot of things at Pekga when it comes to more complex rhythms, right? So you can use your axis of deviation to figure out where your P wave is coming from, where your QRS is coming from, what's going on with the T waves. Really understand what's going on with depolarization using your axis. Okay, so axis, this is upright, this is upright, this is upright, and my colors again are shifting. So this is upright, right? This is upright, this is upright. If you go to the hexaxial system, and there's 3 different methods implement. Again, you can download this in the members area, just log in, everything's free. The most outer rim corresponds to the most basic method. That's looking at leads 1, 2, and 3. So lead 1 is upright, lead 2 is upright, lead 3 is upright. We are in the normal or bottom right quadrant. So the propagation, overall propagation of signal appears to be absolutely normal. You can also use the quick method, and that's using lead 1 and AVF, and you want to see if this is upright, that's upright, The QR, when I say upright, I mean the QRS, right? So the QRS is predominantly positive in both of these, and you have it here in the quadrant, right? So lead 1 is upright, lead AVF is upright, predominantly upright, right? So mainly positive. And this is a quick way of telling you that the signal is ending up, or it's moving towards the bottom right or the apex of the heart. So you're in the normal quadrant, so that's good. Okay, what else? There is another phenomenon here which I am reluctant to discuss because I don't know exactly what's going on with this AVL, but this could be treated as an isoelectric lead. So the signal over here is simply being equaled out. And what I mean by that is, so our lead AVL is really isoelectric or really flat. And what that could mean is that when it comes to electrical activity, lead AVL goes something like this. So this is the line of propagation that it's reflective of. Excuse me. So as you can see here, if we were to draw a 90-degree angle here and draw a line, we would roughly get our lead 2. Now our lead AVL here is very isoelectric, so it just looks like a little bit of artifact on a baseline, versus every single other one is looking very healthy in a sense that we're getting good signal. So what you could do using this isoelectric method, you could say, okay, this is the isoelectric method, and the reason why it's isoelectric because the activity above this line is negating the activity below this line, meaning that the activity above AVL, what's going on here, is equal to what's going on down here, and at this very point, we can expect to see nothing else but this on an ECG. I know this is a whole lot of purple, and in our classes we go into depth with a lot more graphics explaining what that means. But anytime you get an isoelectric lead, you can use it to deduce your overall axis of depolarization rather quickly. Here, I'm not sure that's the case. I don't know anything about this patient. No information was given to me, just the ECG. And I do not want to ignore this, okay? But if you're out in the field, first thing, check out mechanical issues. If that's not the case, this is a red flag that needs attention. All right, let's keep moving. So the axis is fine. I'm just going to get rid of some of these markers. And now, remember here, I mentioned that you cannot be certain that this is atrial rhythm. You cannot even be certain using these 3 leads that this is atrial rhythm here. Whoops, what am I doing here? I'm trying to delete some of this stuff. So you cannot be certain that this is atrial rhythm as well using leads V1 and V5. So what can you do? Well, if you go to your 12-lead ECG, you take a look at your lead 1, you take a look at your lead 2, and you take a look at your lead AVF. If all 3 of those are upright, you have something that's coming from the sinoatrial node. If you don't have that, if you just don't have, let's say, for some reason you just don't have lead AVF, you can go to lead AVR, and you would need lead 1 and AVR. If 1 is upright and AVR is negative, this is coming from the sinoatrial node. There's a great chance for it. It's not 100% certainty, but it is almost 100%. So, but if you have the option of 1, 2, and AVF, use that. If you don't have AVF, use lead 3. If this is upright, this is upright, this is upright, this is coming from the sinoatrial node. Okay, and the reason for that is Now we're really getting ahead of ourselves here, but imagine if you, let's see if my color is going to shift on me. Imagine if you had an ectopic focus that was irritated. So one of these myocardial cells very close to the SA node was irritated, and it was firing at a rate faster than the SA node. So the signal would propagate through the heart in almost identical fashion to what the signal would look like coming from the SA node. There would be virtually no distinction. However, if you were to take a look at that on an ECG, especially a single lead, there's no way you can tell that. And one of the things I really like to do is I like to take a look at patients' old files. So I will, if I can at all, if I have the time to do it, I will always pull the patient's previous ECG. If they were seen, if they have that on file. Sometimes they don't have that on file, and that's okay. You do the best you can. But realistically, what you're looking at here, you're looking at a single channel for 10 seconds. Potentially, you could have something that's known as AV dissociation, where you have an atrial rhythm and you have a junctional rhythm happening, how can I say this, independently. But for this 10 seconds here, for these 10 seconds, they just happen to align properly. That could happen. It's very rare, but it could happen. That's why I didn't want to call this normal sinus rhythm immediately. Now, looking at this, if I indeed had an ectopic rhythm here, there would be slight changes on the ECG as to how the P wave looks in leads 1, AVR, lead 2, lead 3. There would be slight changes, and those fine details we do cover in our lessons. This is not just one giant commercial for our lessons, but it is pretty in depth, right? And we're not here to discuss that today. We're here to discuss this ECG. So let's keep doing that. Okay, so again, not an ectopic rhythm here. There's enough information to confirm that this is coming from the sinoatrial node. Okay, so far we've covered the axis. We've gone into some analytical detail. Let's see here. Yeah, we did talk about this being almost a first-degree AV block. Now, let me discuss that briefly. So first-degree AV block is kind of a tricky beast. But if your patient is under the age of 50, take great care with first-degree AV blocks. They are typically indicative of something far more sinister. So first-degree AV block, right? Your PR interval is what you measure to figure out if you have a first-degree AV block. So your PRI here, you measure. Another way of stating PR interval is you're looking at a time interval from the moment the signal leaves the SA node until ventricular depolarization is initiated by the Purkinje fibers. Once the signal leaves the Purkinje fibers, it enters the myocardium, right? Myocardial cells, and then it goes cell to cell. And that's what you would see as a QRS, right? Your atrium begins depolarization as soon as the signal leaves the SA node. So what you're measuring is your P wave, right? Is the initiation of that atrial depolarization, and your QRS is the initiation of your ventricular depolarization. So your PR interval is telling you how long it takes the signal to travel from the border of the SA node. So once it leaves the SA node, right? How long does it take for it to initiate ventricular depolarization? In other words, if you have a prolongation, if this PR interval is greater than 200 milliseconds, you could have that delay potentially happening anywhere along this path. So anywhere along this path, you could have that delay. Typically, everything is typically. Let me be precise here. From this point on, roughly from this point on, to the point where that signal reaches the ventricular myocardium, this is not visible on the ECG. So this is simply, it just kind of gets negated. So one signal interferes with the other and you just don't see it. But the PR interval, if you have that prolongation, it is associated with something that happened to that signal, something that slowed it down to this point. Beyond this point, that signal gets overshadowed, if you will. But on the left side, the end of the common bundle, so you have your bundle of His, and then it bifurcates into the left bundle and the right bundle. This little segment here, before the further bifurcation into the anterior fascicle and posterior fascicle, is known as the common branch. So down to here is really a reflection of your PR interval. So let's say you do have an increase in your PR interval, you could potentially have an issue anywhere along this path. Why am I saying this? Why am I spending so much time on this? It could be an indication that, for example, your left bundle is failing. It's allowing the signal to pass through, but not effectively. So it's telling you that in the future, this person might develop left bundle branch block. In the future, this person might develop right bundle branch block. Typically, first degree is associated with the transition zone in the AV node, and it's kind of left alone. Who cares? Don't worry about it. But let's say you have a young patient, and they're showing up with a first degree block where you would expect everything to be healthy. You need to take a look at what's going on with that patient. First degree block is something, again, it gets ignored, but do not ignore it, especially with younger patients. So if you haven't tuned out by now, you're probably going to stick to the end. And hopefully this is somewhat interesting. So we have borderline first degree AV block. We have a signal that's coming from the sinoatrial node. We have an issue with AVL. This is all coming from our frontal plane or coronal plane. So, we're looking at the signal moving from top to bottom and from bottom to top, right? Now we're going to shift gears and we're going to take a look at the horizontal plane or the transverse plane or transverse cut. So we're going to switch over to the precordial leads. And here we're going to be looking at R wave progression. So R wave progression is something that doesn't really get enough attention. And R wave progression it's not a specific indicator of anything, but it is an excellent non-specific indicator of something. And what I mean by that is in a normal setting, in a healthy heart, healthy, quote unquote healthy and normal. But in a typical, what you would expect, if the person doesn't have dextrocardia, if they don't have some sort of hypertrophy, other ailments, genetic factors, what you would expect to see is the R wave in V1. And by the way, this is V1, V2, V3, V4, V5, V6, right? The R wave will start off kind of small, but you will have a very deep S wave. And then the R wave will get bigger. And the S wave, in lead 2 it gets bigger still, but in lead 3 they get to be isoelectric. So the R wave is equal to the S wave. And and then what happens is somewhere between lead V3 and V4, the QRS, which was predominantly negative, right? So you had a big S wave, should shift and it will become predominantly positive. This is known as your R wave progression, and it's supposed to happen sometime after lead V3. If it happens before, if it happens after, it's happening that way for a reason. Maybe there's an enlargement in the muscle mass, maybe there's a shift in the position of the heart, maybe there's an ailment of some sort. So there's a lot of babies, but it's definitely telling you something. Okay, now let's get back to the ECG. Looking at this ECG, right? Here's my R wave, starting off nicely, and then boom! Look at this. This is a huge shift. This is a huge shift. It went from something very small to a huge shift. I'm not even seeing that equal phasic, right? The equal parts R wave, equal parts S wave in lead V3. It just went into R wave. So this is what's known as early R wave progression. So there's something causing this R wave to become a lot bigger than expected in lead V3. Again, non-specific indicator, but an excellent indicator of something non-specific. So we have R wave progression that is early, or if you see this ERWP, that's all that means, is early R wave progression. Early R wave progression, when we add this lead AVL to it, there could be something going on here and that's the reason why both of these things are showing up on the ECG. So let's keep going. We've taken a look at the P wave, we've taken a look at the PR interval. The QRS is not wide. The ST segment, I'm not seeing any ST elevation, I'm not seeing any ST depression. The T wave is looking as it should, right? A T wave should have a slow upstroke peak and then a very sharp downstroke, or coming back to the baseline. So this is looking like textbook T waves. What else? Oh yeah, also the TP segment here. When you talk about pericarditis and whatnot, this is a very important thing to look at. But here, I just want to mention it. And one of the things I like to do is I like to take a look at the QT. So your QT is the depolarization and repolarization. And QT, of course, when you measure that, you are trying to figure out if you have a prolonged QT segment, which would indicate an issue, right? Sudden cardiac death and all that. The easiest way to do that is to take, and man, these colors are killing me. All right. Is you take your two R waves, and these are roughly what, 1, 2, 3, 4, 4.33 boxes, big boxes apart, and you find a midpoint. So this is going to be roughly 1, 2, roughly right here. If your T wave does not cross this line, right? If your T wave doesn't cross this line at the isoelectric baseline, you don't have prolonged QT. Those were really thick lines. Let me draw that again. Actually, let's go to a different window. I'm just going to clean this up. Kind of looks weird. But as far as your QT, so the reason I'm going to this window is when it comes to your T wave, this is not a great example to do it on. Let's use a different one, but we're going to be talking about slopes. Let's use this right here. This is good. This is good. Okay, color. I'm just going to make my pen here into a finer point. Oh no, let's use a line. So your T wave, just looking at this, you would say, okay, your T wave, here's your isoelectric baseline. Your T wave probably ends right here. This is really where it comes back to the baseline. No. Your T wave is measured. You try to find the sharpest slope. So as you see this T wave coming down, what you do is you find the sharpest slope, the sharpest point here. And what I mean by that is when you take a look at this, when you kind of look at the slope, oh boy, I need to change colors here. Let's do this. Let's do this. So here, if you were to take, let's say this line was made up of a bunch of points, right? And each one of these points has a little bit of information that it says, that it carries what it says. Your slope here, your rise over run is going to be such and such, right? So when you get up here, the slope is going to be non-existent. It's just going to say you're going to have run. You're not going to have any rise. So your line, as a result, would look like that. Now, as the signal keeps moving forward, your next dot is going to say, okay, here you're going to start falling, so your slope is going to be negative. The next line is going to say, okay, your slope is going to be negative still, even more negative, right? And the next line is going to say, okay, here it's going to be even worse. The next line is going to say, this is going to be the sharpest slope. And then it starts kind of evening out. So the next one says, okay, we're going to start coming back to the baseline. Wow, that looks horrible. But here's the point. I'm going to delete this last one, and I'm going to get rid of all of these other unnecessary ones. When you find your sharpest slope, which is probably something like that here, when you find your sharpest slope on the downslope of your T wave, and you extend that line, wherever that line crosses your isoelectric baseline is the end of your T wave. Let me get rid of this. So the end of your T wave, right? This is your isoelectric baseline. The end of your T wave is not here. It would be wherever this sharpest slope intersects. So, right, you find this line here and you extend that line wherever your sharpest slope intersects the baseline. That's the end of your T wave. This is not the best graphics, but if we go back to this over here, that's why you have this broken up line, right? This is the end of your T wave. So this is your isoelectric baseline where the sharpest slope of the T wave intersects it. So see how here it appears that the T wave comes back to the isoelectric point right here? That would not be the end of it. It would be wherever the sharpest slope intersects it. And in our lessons, when we talk about what's going on in the T wave, what's going on in the cell, that's apparent. But that's kind of a heavy topic. That's a little bit too much for this. So going back to the ECG, long QT. Do we have long QT? We do not have long QT. Going back to the method, what have we done so far? We have covered our wave progression. We talked about QRS. We talked about all of the segments, all of the waves. Now, finally, we have to cap this off with what's going on with the patient. I don't know. No information was given to me about the patient. One thing I do want to discuss here is, let's say that you are indeed looking at normal sinus rhythm, right? So if you were handing this over to a physician and they're asking you, oh, what did you see on here? Can you tell me about the ECG? You would say, okay, I have normal sinus rhythm at 70 beats per minute. And that sounds so textbook perfect that if you left it at that, this ECG would probably get ignored. However, when you add to it that you have early R wave progression, all of a sudden the flag goes up. When you say that there's an issue with AVL and it's not of mechanical nature, a red flag goes up. So far we have two red flags on normal sinus rhythm at 70 beats per minute. And you have a borderline first degree AV block. Now, this is a yellow flag. Again, we don't know anything about the patient. And now, let's say you don't know the symptoms, you don't know anything, but somebody comes along and says, hey, that ECG was taken after a patient ran up a flight of stairs and got into an argument with their spouse. If you ran up a flight of stairs and your heart rate was at 70 beats per minute, that might be a problem. Either you are really ready for the Olympics, or there's an issue and you're not even ready to step out of the house. So when it comes to the method that you are using, whatever the method is, do not exclude what's going on with the patient. All three of these steps in combination will allow you to make an ECG analysis, which will make the physician's job easier at diagnosing what's really going on, right? So ECG is just one of the tools that's being used in a complete diagnosis. This patient might have come in for, I don't know, a broken foot, and the ECG showed an issue. So, deep dive. I think that should about cover it. Hopefully I didn't kind of lose you guys in some of those segments. Let's see here, right? So this is the method we're using. All of this stuff you can download at pekga.com, and you can use it. You can use it for whatever purpose you'd like to use it for, but you do have to log into the members area. And that's it. That's it. Again, before I sign off here, there is a link in the description to a very rapid ECG interpretation. So this exact same ECG is just without going into any deep details as far as what it is that we do, how we do it, and so on and so forth. So feel free to check that out. Otherwise, we'll see you on the next one. Thank you for being so patient with me.